So did you expect that?
Okay, welcome everyone to our first Lunch and Learn of spring 2024. And thanks for coming. I know this is a larger room, but Dr. Derek Falk will warm it up and make it feel a little smaller for us. And thanks to everybody who's joining on Zoom. Today's topic is about distress and cancer screening adherence, and it's really helpful to have some of this connection with our health specialization, our aging specialization. There's so many overlaps within our program that connect to health. So we're really fortunate that Dr. Falk could join us today, and I'll turn over the program to Dr. Aloan Townsend to do his introduction. Thanks, everyone.
So good afternoon, everybody. I am Dr. Aloan Townsend from the Mandel School. For those of you that I haven't met yet, nice to meet you. And this is Dr. Derek Falk. He's an assistant professor in the Department of Population and Quantitative Sciences, which is within the Case Medical School, School of Medicine. And he's also a member of the Case Comprehensive Cancer Center. Dr. Falk received his MSW from the Brown School at Washington University in St. Louis and his PhD in social work from the University of Texas at Austin. He also was a postdoctoral fellow in the Department of Social Sciences and Health Policy at Wake Forest University School of Medicine. He is a behavioral researcher investigating supportive care services across the cancer continuum to improve screening rates and survivorship outcomes for individuals marginalized due to their race or ethnicity, their sexual orientation, gender identity, language abilities, residential location, or socioeconomic status. So a very big focus on intersectionality and disparities that I think you'll find interesting. Dr. Falk's research portfolio includes an American Cancer Society funded evaluation of breast and cervical cancer screening outcomes of the largest patient navigation program among rural and border residents in Texas. And he has worked on multiple National Cancer Institute funded supplements during his postdoctoral fellowship at Wake Forest. He is currently working on the grant entitled Partners, Promoting Access, Resources, and Treatment through Novel and Equitable Solutions for Cancer Care. This is funded by the Merck Foundation's multi-institutional $20 million initiative to advance equity in cancer care. His research also includes a study examining lung cancer screening using a team science approach for low-income Black residents of Cleveland, Ohio, awarded by the National Institute on Minority Health and Health Disparities. And as you just heard, this is the title of his presentation, and please join me in welcoming Dr. Falk.
Thank you so much, Dr. Townsend. It's a pleasure to be here. So as you heard, I'm actually a social worker by training, PhD and MSW, but a lot of my work is in cancer, so it kind of spans both of these areas. So I really wanted to start out. Okay, just kind of introducing myself to MSAS because I've met some folks here. But not everybody, of course. And but I'm happy to be here. This was MSAS is actually one of the key motivational factors for me to come here when I was interviewing for positions with such a strong school of social work. So I'm originally from Kentucky, a small town called Madisonville, Kentucky, which is about right there in the state. So I come from a rural background. And, I started out my academic journey at the University of Kentucky, where I studied international economics and Spanish. A lot of this was inspired, honestly, by my mother, who worked in despite being a rural small town, we had a fairly substantial hospital that served the rural region that I lived in. And interestingly enough, they built some chicken plants very close to us. So we had this, all of a sudden, when I was in high school, this huge migration of Hispanic, Latino, Latinx populations that all of a sudden moved in. And she worked in OBGYN and was servicing them, and I was translating for her quite frequently. So in between undergrad and grad school. I lived in Mexico for 3 years, taught English and just kind of, lived a bohemian life a little bit. When I came back to the US, I actually worked in international finance for large corporations. And most of the time I spent was in El Salvador and Honduras. So you probably don't recognize those, but that's San Salvador and San Pedro Sula in Honduras. And also, this was during my graduate studies, but I also spent some time in Brazil. Not so much in Rio, but that was probably the most identifiable factor. So from there, when I came back to academia after that stint of about 5 or 6 years, I started out at the University of Louisville, studying Spanish and Latino and Latin American studies, because I was very interested in this interplay of like how migration was affecting our population in general. And I didn't know that this would be my path, but somebody told me, it's like, you should do medical interpreting. You're really good at this. And so once again, I found myself in healthcare and started realizing, the disparities landscape and what that meant, especially for a lot of uninsured, undocumented individuals. And really at the heart of that practice, a lot of the people that I worked with were primarily social workers in these settings. So I worked a lot in what they call federally qualified health centers. So if you're familiar with those, there's several around here in Cleveland. And that inspired me to pursue my graduate studies in social work. I never had really seen this role before, especially in healthcare. And I went to the Brown School, as Dr. Townsend mentioned, and got my MSW. And then from there, I, again, still wanted to focus on the same population. So I ended up at the University of Texas at Austin, where I studied a PhD at the Steve Hicks School of Social Work and also in the Population Research Center, which was a very large initiative there. And eventually I found my way to North Carolina, where I did my postdoc at the Wake Forest School of Medicine in cancer prevention and control. So just to summarize some of my research interests, I look a lot at language-based acculturation and its impact on health and mental health. I also look at distress. This is kind of not a necessarily completely new area for me, but a new focus, I guess I'll say, that I'm looking at in the context of health, particularly in cancer, of course. And but other aspects of my work include community partnerships and team science. So team science is kind of like a multidisciplinary, interdisciplinary work that spans specific academic disciplines. So another word you might use to describe me, or another title, is a public health social worker. So I look at individuals and communities, as well as using epidemiological techniques in my work, looking at social and economic factors, as you can see from my work, and looking at prevention and not necessarily always survivorship outcomes, and advocating for the populations that I serve. So some of the terms, since you may not be familiar with the cancer world, we have our own language, honestly. So there's the cancer continuum, and it starts out with screening. So basically this is like pre-cancer, right? So you don't have cancer, but in the general population, there are recommendations for screening for very specific cancers based on age. Then you have diagnosis. So should be pretty obvious. That's when somebody would be identified as having cancer. And then after that, the next phase would be treatment. So active treatment when people are undergoing chemotherapy, radiation, surgical procedures, et cetera, immunotherapy. And then survivorship actually encompasses 3 of these. So it starts at diagnosis. So this is a conceptual way of saying an individual that has had a history of cancer is another way of saying it. But oftentimes it refers to people that are post-definitive treatment. So post-definitive treatment is hopefully remission, right? So you're cancer-free, but you still have the after effects of your cancer treatment and diagnosis. And it's not only physical, it's also social and mental. So These aren't the only ones, but just to give you an idea of the age groups that I tend to focus on. It tends to be 40 plus, right? So that's for these specific cancers. There are two more: prostate cancer that can be screened for, and also skin cancer, which is they're a little bit different than these. These are the ones that at least have ratings. And cervical cancer being the one that is kind of the outlier that begins at 21. So you have this idea of like what distress is across this continuum. So screening age populations. So what does their mental health look like in general before they ever get cancer? And that's where I'm actually going to focus on for the most part in this presentation, which sounds perhaps a little unusual, but I'll get to the reasons why. Then you have the period between screening and results, which is very short typically, but you can imagine the anxiety that somebody might have if, for example, you feel a lump in your breast and then you go for a mammogram and then you have to wait a while to figure out like what that diagnosis is. There has been a lot of literature on that. Of course, at diagnosis, so you can imagine the impact, the mental health impact of somebody telling you, a doctor telling you that you have cancer. A lot of people study distress at that point. During treatment, so cancer, depending on the type of cancer, it varies, but it tends to be a lengthy process. So you might think a year, 2 years, maybe more, depending on what type of cancer it is and the complexity of it. Severity. So people go through a range of emotions and mental health crises perhaps during that time. And then of course, the post treatment long-term effects. So just because you go into remission or you're considered cancer-free doesn't mean that you're not going to have mental and behavioral effects well across your lifespan. A lot of most people have not focused on that. So this is hypothetical. I didn't actually do these numbers, but just to give you an idea of like the types of studies and where the majority of the interest lies. Most of it I would say would be in treatment because that's an active, captive audience, honestly, for researchers to do their work in this area. And then post-treatment, I would say would be the next most common, where people are actually actively doing, cancer survivorship research, which is a lot of the focus that I saw in my postdoc. So some at diagnosis, and we'll see some examples of these in after screening, but very little in this area of screening. And that's where I'm kind of like, so why would I study this area if it's not very popular to do this type of research? Well, I'm going to give this case of women's health. And the first thing that I want to discuss is the fact that obviously I know the difference between gender identity versus sex assigned at birth, right? So when I say women, it's in the context of understanding these two concepts are not mutually exclusive, right? But it's sometimes the way that they're defined in these studies. And so I have to go with the way that they're defined in the studies as opposed to perhaps what my definitions of them would be. And I want to start out with this idea that 90% of Americans say that there is a mental health crisis. So this is a substantial amount of individuals. And in fact, even in my intro to public health course that I'm co-teaching right now, the lead instructor asked our students, what do you think is the number one pandemic that is happening right now in this country? And our students, by and large, said mental health was the number one. So these are all going to be from the same study because it was so good and the slides are so easy to do. But you see this disparity first by gender, as defined in this study, right? That women aged 18 to 64 have significantly higher rates of need for mental health services, is the way that they described it. And then you see trying to get that within the past 2 years, there is also that disparity with more women trying to get mental health services. And when you look at women alone, So of those 50% that say that they need it, you see it's actually younger women that have significantly higher rates of needing mental health services. Not so much racial ethnic differences, except for the fact that Asian and Pacific Islander women have lower rates of needing mental health care. But you see, again, where I intersect in this a lot is income and insurance. So income, basically poor women needing more mental health services, and those that are on Medicaid as opposed to, which correlate quite well. But the interesting thing is, 40% of them did not even try to get mental health services, and then 10% of them tried but couldn't get them. So there's an obvious gap where we need these services. And one of the slides that I could not find, and I couldn't find a really good source, but I think that we know it as mental health practitioners, is the fact that there's simply just not enough resources, mental health resources out there, that we actually need more mental health practitioners. And that's hopefully what some of you are training for. It can be diverse, but in order to cover this gap. So, and I also want to talk about the case for equity. So there's this idea of behavioral health equity. So again, that idea that the gap exists between our health services that are inadequately covered, really, if we really want to get down to it, and then behavioral health, which is even less covered, but that everyone, right, no matter what, way that you identify yourself as in whatever category, should have access, equal access to affordable, high quality mental health care services. So this is from Samsung. And when we talk about equity too, prioritizing, especially racial ethnic groups, they're certainly not the only ones, but we see the same level of disparities that we do with any other health condition, overrepresentation in marginalized or minoritized communities than compared to the general population. So how do we connect those individuals that need mental health services with care? First of all, there was an act in 2008 called the Mental Health Parity and Addiction Equity Act. And so this basically outlined that insurance providers especially had to provide equal access and pay for services equally as they would do healthcare. So that's aspirational in a lot of ways, right? We don't actually have that, and it's mostly because of, well, I will say insurance companies have also tried to fight this in some ways too, unfortunately, but we don't have it because we don't have, again, the parity of practitioners to even service individuals in need. So when you talk about, so the Department of Veterans Affairs, they have done a lot of work, and they're a great kind of model to go by because they look at this idea of a patient-centered medical home, which is like a comprehensive care services. So I typically say care services rather than health or mental health services because it's comprehensive, it's whole person, right? Patient-centered care. And when you look at this one, this integrated model that's been mandated actually, right, by the PACs, catalyze improvement process that encourage collaboration, innovation, adoption of best practices. So really, and they're at the forefront too of implementation science, if you want to go there too, about quality improvement of how do you do care services in a high quality way. So want to point out some of my colleagues from UT Austin in particular talking about how social workers are really key in these integrated healthcare systems to address social determinants of health as well. And it should be mental health as an equal share. So again, integrated primary care is essential. Here we have from the American Psychiatric Association, this collaborative care model. And that's where you see kind of like a diagram. I just like the diagram more than anything, that you have the patient in the center there, but you have this connected interaction between primary care, behavioral health care managers. So that would typically be social workers. And then, of course, you know, as it is from the American Psychiatric Association, the psychiatrists there. But the fact that all of these people work in tandem, thought it was a good way to kind of illustrate that, to provide care services comprehensively. So the association between primary care used to cancer diagnosis and subsequent mortality. So again, with the Veterans Affairs Health System, thank you. Sorry, it's warm for me. We see that PCPs are, so this is getting back to the idea of screening and the value of primary care to screen for cancers. And you see that that PCPs are vital for this. Most of my work has actually been in the community. So looking at how we interact with community outside of care centers, but really PCPs are really integral to provide, especially recommendations for these screenings in their context. Another study looked at depression and referrals among for cancer screening with patients with breast cancer. So you see that even in this study, which was a small pilot, 47 women with mental health disorders were not receiving any type of depression care despite needing it. And you see this connection between mental health screening services with cancer screening diagnostic programs. Another study here looking at the barriers to cervical cancer screening. So this is a qualitative study, looked at the need for tailoring screening services to address the unique women, the needs of women, and to facilitate that activation of trust between patients and providers. Another one looking at cancer screening, another qualitative one, and mental health service users. So we know that there are specific barriers to cancer screening uptake for mental health service users that prevent the equality of care. So these have been addressed by some researchers. This one I want to point out specifically, even though it's that period between the abnormal screening, it's a diagnosis by Kathleen L. And if you don't know Kathleen, she was a social work pioneer, really, who has since passed on in 2021, but she really kind of was a model that exemplified a lot of the work that I do. You know, as they quoted here, the patient's self-care management is heavily influenced by choice, stigma, culture, practice, behaviors, physical health combined with context support barriers, contextual supports and barriers. Her work is very transdisciplinary, as mine is, and very community focused, as mine has been too. And she also was one of a very early adopter in the day of patient navigation, if you've ever read her work. So I'd recommend referencing her at some point in time. So another one, another study here, as I'm developing my ideas, looking at cancer screening prevention in people with mental illness. And what they found here is that the individual, interpersonal, and organizational, community, and policy levels that are needed. So this is across the spectrum of interventions, right? So it's not just at the individual level that we need to interact in order to improve cancer screening among people with mental illness. And this, again, intersects with the idea of disparities in these different minoritized groups, and how you see here that these were drivers of lower colorectal cancer screening in this study. It's also global, so it's not just talking about you know, obviously we focus so much on the US here, but you know, we can think about this even in a global aspect too. So what are we doing here locally? You know, as Dr. Townsend mentioned, I'm working on this project here called Advancing Equity in Cancer Care, funded by the Merck Foundation. And what this initiative does, looks at improves coordination of care through diagnosis through survivorship. So we're actually not, that's the funny part. It started out with screening, but they have kind of shifted their focus more towards diagnosis, and at that point navigating individuals. And so this is actually patient navigation at this first one, strengthening the patient provider communication. So as I focus on especially language and the use of language in interpreters in medical settings, and building community partnerships. So here locally, we have 4 partners, but this is also a consortium of 9 different academic institutions and large organizations as well that focus on cancer care. And then finally is disseminating our findings both at the local level and at a national level to demonstrate how to perform equity-focused work, which is still very nebulous in a lot of ways. One of our partners that I want to point out is El Centro. So it's in Lorain County. If you've ever heard of this nonprofit organization, they do a lot of work it's across the board of types of social services, and they're actually focusing much more on health and working with Lorain County Public Health Department to build a local FQHC there in Lorain County. And also the Gathering Place, if you've ever heard of this organization, hopefully, okay. I was thinking that this would be a great partner. So obviously a lot of social work interaction there, as you can see, and what we're using to, but they're actually focusing on this aspect of looking at cancer screening as well. So it's mostly been survivorship has been their area of emphasis, but they actually are kind of, you know, looking at changing their focus to broaden it based on the needs of this program. And one of the last things I'll mention is just right now, like, what am I doing? I'm looking at, I don't have the data yet, unfortunately, but looking at the National Health Interview Survey to assess cancer screening outcomes using distress as a predictor in these models, which I think will provide a nice basis. So a lot of the work you saw was qualitative in this area that I was pointing out, but it's actually, I think that this is a needed study to look at this very broadly and globally and have a national representative study. Long term, I can see other directions that we can go in to other chronic conditions, including HIV and AIDS, diabetes, heart disease, and other comorbid conditions. And with that, and I know it's plenty of time, but I would like to open it up for any questions or comments that you have. Sorry, I'm so warm.
So I'm interested in this part of like a language acculturation and during the health screenings. When it comes to mental health or distress and physical symptoms, are you seeing any big differences in how people with fewer English skills or different or Spanish speaking people have a different conception of like psychosomatic type symptoms or how they sort of think about the etiology of this disease?
Within cancer specifically, I cannot say, but I have seen studies that have looked at medical interpreters, and what you see is really kind of just the disparity that they have of like understanding the healthcare system. You know, when you talk about the way I look at it too is like a facilitating trust and mistrust, right? So not trusting the healthcare system, especially when they don't have providers that can speak their language. I don't know though, specifically about your question about, you know, how that affects the etiology of the outcomes. But that's a good question. Yeah.
Have you looked into like doing mindfulness at all with some of these?
I'm sorry, what did you say?
Mindfulness.
Mindfulness.
Something you looked at or?
I have not, unfortunately, the intervention, I guess, to screen an individual for cancer is fairly brief. And so the idea, because you're looking at it from a population level of like, how do you screen, a population of people? But the thing I would mention is, okay, sorry, the interplay of screening for mental health conditions at the same time. But yes, like in the survivorship literature, definitely a lot of mindfulness interventions have been played out in that in those types of studies, especially like with depression and distress in general.
I started interning at a small nonprofit that provides hospice care for those who are unhoused. And uninsured and don't have a caregiver. It's a hospice home setup.
Okay.
But we were just looking into cancer treatment. And I was chit-chatting about it, just listening to you talk, like, are there any measures for the unhoused population in terms of screening? Like, does anyone look at that, like how they get access to those services or linked up?
Yes, yeah. As far as, again, from a public health standpoint, yes, they've done screening studies of unhoused populations. Do they look at distress? Do they look at, so like, describe to me, how is it is it like palliative care? Okay, so unhoused individuals with like chronic conditions and their end of
so
life?
It's like a group home setup essentially. And so we partner with hospice. So, yeah, basically at the end of life, there's that 6-month window with end of life illness.
Okay.
So if you have that terminal illness, we'll take you in and it's just free hospice care. It's a group setting.
Okay.
So we're just working to try to figure out how to access that population. We have like 6 beds at this point. But I'm like, how do we intersect those cancer screenings, into that as we come across services? It's just
yeah. I guess it's just the idea of like, if they're in palliative care or hospice care, would they need to have cancer screening? That's where I would
I
question.
guess I'm thinking more grassroots, community based,
Uh-huh.
like unhoused on the street.
Oh, yeah. There's definitely literature out there
Okay.
that talks about.
Yeah, I'm thinking more like outhouse community based
yeah.
services.
Yeah.
Okay. And then in terms of the language kind of question, or I don't remember the exact words, but is there literature around like trauma informed language? Incorporating that framework into these like.
I know, actually, I don't know. I honestly, I'm not familiar with, I've never approached the literature that way. But that's a good point. Honestly, in a way, I'm also looking for feedback. No, that's actually really good feedback. This is what I'm thinking. I'm like, oh yeah, trauma informed perspective on this would be very interesting to assess.
And having that language like coded in the healthcare system at any level of service, I just feel like would, make the unhoused maybe a little less afraid of all the facilities that are trying to connect with them and provide services. So I was just, because they're, trauma, I can just see how you could create sort of trauma like language to make that easier for people. But I totally agree. Again, I hate to say it, it's like, it's going from one field to the other and that's where, but I see that's where there's an opportunity to kind of like really explore a broader, more kind of patient-centered whole person care that is lacking, quite honestly. I hate to say that, in the public health literature. So that's actually, no, I'm taking notes myself. Yeah, I just like in terms of like grassroots measuring, like actually, how do you do that from? Because that's where I'm coming from as a social worker, right? Because that's my population,
Yeah, exactly. That's your population.
CE opportunity coming up. I just got a notice for, I believe it was from University of Missouri in St. Louis.
Oh, UMSL? Yeah.
It's going to be a workshop online. I'll try to dig it up again. Send it out. That was looking at language and trauma-informed language so there are people that really are very sensitive to that, and
But
Um,
is,
One of the people who's been most instrumental in looking at that is Terry Altilio, who has been instrumental in focusing on pain and healthcare. So I'll try to look that up and then send it to Melanie class to put in the announcements.
interesting. Yeah, I'd like to see that reference too.
Sure.
But it's not necessarily foreign language, right? Or, yeah, you're just saying the language that we use to.
From my perspective in the healthcare system, I did a little work at like a psychiatric hospital.
Uh-huh.
It was privatized, but it was like the least trauma-informed system I'd ever worked in. So like, just to be honest, it was, yeah, scary, from a social worker perspective, who most of my experience before that was working with victims of crime. So doing, social work in conjunction with police.
Oh, wow. Yeah.
So it's like my whole framework of my practice is like the language that you're using and being a liaison between like the police or this victim of crime or like, you know, the patient and the hospital or whoever's providing the services and like, yeah, it's just, I can clock it when I'm in like healthcare settings. I'm shadowing like a cancer setting tomorrow, like I'm just seeing it everywhere in that system that they're just like lacking that perspective. But you need the licensing in healthcare to get the services that people need, right?
Yeah.
So it's like, there's like that gap there that's like, yeah, it's tough.
Yeah, no, that, I mean, like I said, there's a lot of opportunity to kind of like bridge that gap and, you know, that was the interesting thing. So I worked for, it was kind of part-time ad hoc, but when I was in Kentucky, I mean, I was doing medical interpreting for like 2 or 3 years. And the ethics of interpretation is just, it's only the message, right? It's only what the doctor's saying. You're not allowed to advocate, suggest, you know, have really even a dialogue with the patient, which is really bizarre. And that's where I found social workers. It's like, I couldn't do that, but I could say, talk to that person, right? And that person could be the voice and I would just translate the message for them. And then I was so frustrated by that. I'm like, I might as well just become a social worker, you know?
It's interesting that you mentioned that because my previous work, I would do like rape kits or sexual assault exams in Lorain County, actually.
Oh, yeah?
At their child advocacy center, yeah, and so we serviced a lot of Latino individuals and yeah, I was like a liaison between, you know, I serviced those who spoke English, however, there's like this whole layer of like, how do I try to describe this? Like I was basically doing what you were saying, where I was like, this is a really scary situation and how do I have this make sense to the kid? And then we would have people who did speak both languages come in and provide that as well. But it was just, you talk about like how sensitive it is. I mean, we're collecting evidence for a criminal case in that situation. So like the language has to be very delicate. Yeah.
No, exactly. And that's the reason, you know, is interesting. I would never do legal interpretation. So there was like kind of two basic services because first of all, the reason why I was doing medical, right, is because this is actually covered again by policy that says, you know, healthcare settings have to have the service. A lot of people use language lines, but I was fortunate enough to do it in person.
Yeah. Okay.
But I would never do legal.
Yeah, it's
Because
weighted.
everything you say.
It's very weighted.
Exactly.
Yeah, so.
And if you misinterpret or, you know, it was weird even down to the point where they would not let you use like notes or dictionaries you shouldn't probably, but you know, and the crossover, at least with Spanish and English with the medical terminology was fairly easy. With legal terminology, it's much more complicated.
Yeah.
Well, and I wonder off of that, like, when screening patients for child abuse, elder abuse, neglect, those types of things, what is the process for making sure that is communicated in a way that, you know, because there is so much shame and stigma and, you know, if their partner is there who is abusive, they're going to be, you know, walking on eggshells around it.
Yeah.
So like what, in addition to that kind of like trauma informed lens, what are we doing linguistically to ensure that you're picking up on those subtleties that might mean I'm being abused or something like that?
True, yeah. I mean, that's where I found like interpretation very limiting, and especially like language lines, right? Because that's even more limiting because there are so many visual cues to language that are beyond the scope of just that message and just those words and the translation that do get missed. You're right. And that's why I guess even though I'm advocating for this, it's like, gosh, learning different languages, and the value of that. So if you look at it's called family healthcare practice. It's an FQHC on one side.
Neighborhood family practice?
Neighborhood, yeah,
Oh,
that's
yeah.
what it is.
I know what you're talking
Neighborhood. So, and they were saying to me, I talked with some of the reps there that, upwards of like 30% of their population speaks another language than English. And it's not just Spanish, right? It's Arabic, it's, Eastern European languages, et cetera. And it's really, really difficult, especially as a provider, if you don't speak those languages to understand everything that you need to do. So, no, those are good points, really good points. Any other?
I just have a question about the data that you had shared. So amongst, and I know you said it may be a work in progress, so you may not have the answer to this, but amongst the population who is eligible to receive cancer screenings, like based on the age, right?
Oh, yeah.
Is there a difference in mental health amongst those who are being screened versus those who are eligible age to be screened but not getting screened?
That's what I want to find out with my study,
Okay.
right? Is
Yeah.
that if you have, and I think that this hypothesis is true. This is my hypothesis, that if you have, because it's sad because national level data is not very specific, but they do have the PQH9, the GAD7, the Kessler-6 embedded in these surveys. So you can say, okay, this person has an elevated level of distress, depression, anxiety, and like you said, they're not getting screened, right? They're not adherent. So I mean, actually, that's another word that I didn't describe in my terms, but adherent meaning that for most cancer screenings, right, you don't just do it one time. You should do it on a regular interval. So, with breast cancer screening, mammography, it's every 2 years. Cervical cancer screening has gotten kind of complex because it's depending on whether you've had the HPV vaccination, and then it's like every 3 years, and et cetera, et cetera. Prostate, that's why I didn't even put it on the map because it's so complicated. But yeah, that's you're getting exactly to the point of what I want to explore.
I guess with that hypothesis, it could really go either way, which is kind of exciting with a research question, right? Because I could see that the subset of the population that already has underlying anxiety may be more vigilant and thus want to go in for screenings.
Exactly.
But I could also see the flip, right? Of if you have mental health, maybe you dismiss other things as priorities because maybe you're focused on your mental health, or maybe you're a little bit more absent-minded in general because of the mental health diagnoses. So,
True. Yeah, no, it could go either way. And the way that I'm going to do this, I know we're running out of time, on a population level is looking at a trend analysis and really, as we know, is that the 90% statistic that I showed, COVID has impacted us tremendously, not only at the acute period of the pandemic when we were all enclosed, but now post-pandemic of how our mental health has not gotten better, and that's why I want to kind of like do it as a trend analysis and see over time. And that's the thing about epi studies. Epi is so large, not very specific, but hopefully it informs a more specific approach that I can use on an individual level basis. So, one more question.
For the different types of cancer screenings, are you taking into account like the cost? I don't, not super familiar with, but like, are they covered by Medicaid? Are they covered by Medicare? Like, or how much would the copay be? Are you accounting for those factors?
In the national data set, I mean, I can look at their insurance status, yes. So exactly like you saw with the mental health figure that I put up there. But not so much, it's a little harder to do. Cost, if they're covered by insurance, it should be 100% for screening. No matter what that screening is. Diagnostic is not, right? So that's another complexity and that's the reason why those, that anxiety between getting screened to actually getting diagnosed may be even more enhanced due to the cost aspect that may be playing a role in it. Yeah.
So late today, but I was thinking about collecting data, self-reporting around mental health, and just like anecdotally as a patient at the Cleveland Clinic, whenever I have an appointment now, even if it's not related to mental health, there's a questionnaire to fill out beforehand.
Exactly.
And it asks me to like rate my mental health on different categories. And then at the end, it says like, do you think this will help your physician like better assist you today in your appointment? And I think about that data because it's like relatively like recent survey that they started asking patients and through the portal. And sometimes I wonder like where all that data goes.
Right.
And it seems like a helpful tool to collect larger quantities of data.
Definitely, but and we also have to be careful too about collecting this data and not falling through, right? So if you see that somebody is depressed or anxious or has some of these conditions, do they have the integrated care system, right, to actually have a behavioral provider that would address those issues?
Oh, no, I'm just.
Oh, okay.
afraid.
Oh, okay. I thought you were-
Like,
Yeah.
Big gap, actually, the Kaiser Health Foundation is putting its finger on right now is all of the data that's mandated to be collected in
Yeah, they
healthcare
do
settings
mandate.
on psychological distress. With no follow-up. They've also had a couple of studies where when the hospital followed through, they then charged the patient for the mental health referral. So it's a really important thing
Complicated.
that's happening with that data.
Thank you so
all for-
much.
Thank you. No, thank you. This was a great discussion. Thank you all for coming and attending. And if you'd like to receive a copy of the PowerPoint, just let us know. We'll send that out to you. And I hope you have a great week. Thank you so much.
Yeah, that's what I was hoping for. That I would get like more insight.
How was the tour, dude?
It was good.
It was really cold.